On a freezing October night, a black father rushes into the ER with his 5-year-old son burning with fever, struggling to breathe. The parents beg for help, but the head doctor sends them to wait while wealthy white patients are seen first. The boy grows weaker by the hour. His mother whispers, "They'll help us," not knowing their trust is being betrayed by hidden prejudice. What no one realizes, this father is the hospital's biggest donor. Before we dive in this story, let us know where you're watching from. We love to hear your thought. At 3:12 in the morning, the automatic doors of Grace Memorial Hospital slid open with a sharp hiss, cutting through the silence of a cold October night. Wind rushed inside, carrying with it the frantic footsteps of David Coleman, a 45-year-old father whose chest heaved as he clutched his little boy against his body. Caleb was only 5, his small frame trembling violently, his cheeks flushed crimson with fever, his eyelids pressed shut as if the world itself was too much to bear. Monica, his mother, stumbled close beside them, her hair hastily tied back, her face pale from fear, her hand gripping her husband's shoulder, as if holding on to him would keep them both from falling apart. David's voice cracked as he shouted for help, each word soaked in desperation. His heart pounded like a drum in his ears, drowning out everything except the shallow, ragged breaths of his son. Behind the reception desk, Amanda Brooks, a young triage nurse, looked up from her computer. Her training kicked in immediately. EMTALA required assessment of every emergency patient, regardless of ability to pay. But as her eyes took in the sight before her, a frantic black couple in worn coats and shoes that had seen better years, carrying a limp child, her response carried undertones that had nothing to do with medical protocol. "I need to get his vitals and basic information," Amanda said, her voice professional but perfunctory. She took Caleb's temperature, 104.3 degrees Fahrenheit, and noted his rapid pulse and labored breathing. These readings should have triggered immediate pediatric emergency protocols, but instead she assigned them to the general triage queue. "You can have a seat over there. Dr. Sterling will see him as soon as possible." The waiting area was crowded for a weeknight. A businessman in an expensive suit clutched his chest, speaking loudly on his phone about chest pains. A teenager from the suburbs sat with his parents, icing what appeared to be a sports injury. An elderly woman coughed persistently while her daughter filled out insurance forms. Each represented a different level of perceived urgency in the informal hierarchy that governed emergency care. David wanted to shout that his son was 5 years old, that he'd been having seizures, that something was terribly wrong. But Monica, drawing on her experience as a nurse, placed a calming hand on his arm. "They know what they're doing," she whispered, though her voice carried doubt. "These things take time." After 18 minutes that felt like hours, they were called back to examination room 7, not to the pediatric acute care area, but to a standard room in the general emergency section. Monica's nursing instincts told her this was wrong, but she pushed down her concerns. She wanted to trust the system she had once been part of. Dr. Howard Sterling, head of emergency medicine at Grace Memorial, finally appeared 42 minutes after their arrival. 57 years old with silver hair and pale blue eyes, Sterling carried himself with the authority of someone accustomed to being the smartest person in the room. But when he looked at the Coleman family, what he saw wasn't a medical emergency, it was a case that would consume expensive resources for what he assumed would be inadequate compensation. Sterling's examination was thorough enough to meet legal requirements, but lacked intensity. He checked Caleb's throat, listened to his chest briefly, and palpated his abdomen with the detached efficiency of someone going through motions. "Febrile illness, probably viral," he concluded, not bothering to sit down or make eye contact with the parents. "We'll run some basic labs, start fluids for dehydration, should be able to discharge him in a few hours with follow-up care." David felt his throat constrict. "Doctor, he's been having seizures. The fever won't break no matter what we give him. Are you sure this isn't something more serious?" Sterling's response revealed the calculated dismissiveness that governed his interaction with certain families. "Mr. Coleman, parents often mistake rigors from fever for seizures. It's very common, especially among," he paused meaningfully, "families who aren't familiar with pediatric illness presentations. I've been practicing emergency medicine for 20 years, Trust me, I know what I'm seeing. The condescension was deliberate, designed to silence questions and establish hierarchy. Monica felt the familiar sting of being talked down to, but her nursing training made her push back gently. Doctor, I'm a registered nurse. I know the difference between rigors and seizures. My son had tonic-clonic activity for nearly 2 minutes. Sterling's expression hardened slightly. Mrs. Coleman, even healthcare workers can lose objectivity when it's their own child. That's why we rely on professional assessment rather than parental observation. What he didn't say, but what his tone conveyed clearly, was his assumption that a black nurse couldn't possibly have the same clinical judgment as a white physician. The dismissal was complete, professional, and devastating. The emergency department that night was a study in priorities made visible. While the Colemans waited in room 7, Sterling moved efficiently between other cases. The businessman's chest pain, which would later prove to be anxiety, received immediate EKG monitoring and cardiology consultation. The teenager's sports injury was fast-tracked through X-rays and orthopedic evaluation. An elderly white woman with abdominal pain was admitted for observation within an hour of arrival. Each of these decisions was defensible individually. Each could be justified by medical protocols and standard procedures, but taken together, they revealed a pattern of resource allocation that consistently favored patients who looked like they belonged in Grace Memorial's upscale neighborhood. Sarah Martinez, a young nurse assigned to monitor Caleb, found herself caught between her training and the institutional pressures that governed her work. She had seen the lab results that came back an hour after Sterling's initial assessment. Caleb's white blood cell count was dangerously elevated. His blood chemistry showed early signs of organ stress. These findings suggested serious bacterial infection requiring immediate intensive treatment. But when she approached Sterling with the results, he barely glanced at them. "Continue current treatment protocol," he ordered. "We'll reassess in the morning." Sarah wanted to push back, wanted to advocate for the little boy whose condition was clearly deteriorating. But she was 26 years old, carrying student loans that would take decades to repay, supporting her own sick mother. She had seen other nurses disciplined for questioning physicians' orders. The system that employed her was the same system that fed her family. Meanwhile, in the ICU 3 floors above, Dr. Jennifer Park was finishing her shift when something made her glance at the emergency department's patient roster. A 5-year-old with high fever and documented seizure activity, admitted 6 hours ago, still in general emergency observation. Her pediatric training set off immediate alarms. She called down to the ED. "Amanda, I see you have a 5-year-old with fever and seizures. What's his current status?" Amanda Brooks hesitated. She had been watching the clock, knowing that something felt wrong about the Caleb Coleman case, but unwilling to challenge Sterling's authority directly. "Dr. Sterling has him listed as febrile illness observation status. 6 hours of observation for a febrile 5-year-old with seizures and abnormal labs." Park couldn't hide her concern. "Amanda, those vitals and lab values suggest possible sepsis. Dr. Sterling is the attending Dr. Park. I'm sure he's considered all appropriate diagnoses." But Park was already moving. Her instincts, honed by years of pediatric emergency medicine, told her this case needed immediate attention. When she arrived at examination room 7 and saw Caleb, the grayish pallor, the labored breathing, the way his small body seemed to be losing its fight, she knew immediately that this child was in serious trouble. "How long has he been like this?" she asked David and Monica, her voice carrying urgent concern. "Hours," Monica replied, her nursing assessment finally finding voice. "His blood pressure has been dropping, his breathing is getting worse, and no one will listen to us." Park quickly examined Caleb, her trained hands and eyes confirming what the parents and lab results had been saying for hours. This child was showing classic signs of septic shock, a medical emergency requiring immediate intensive intervention. Dr. Park stepped outside room 7 and immediately called for a pediatric code team. The response was swift and professional. Within minutes, specialized nurses, a respiratory therapist, and additional physicians converged on the room. The quiet corridor erupted with the controlled chaos of medical emergency response. Dr. Sterling appeared, his face flushed with anger at having his authority challenged so publicly. "Dr. Park, what exactly do you think you're doing? This is my department, and I don't appreciate you overruling my clinical decisions. Park stood her ground, her voice steady with the authority of someone who specialized in saving children's lives. Howard, look at this child's presentation. His blood pressure is 82/48, capillary refill is 4 seconds, he's tachycardic, and showing altered mental status. His labs show leukocytosis with a left shift and elevated lactate. These are textbook signs of pediatric septic shock. The code team was already working around them, starting additional IV access, drawing blood cultures, preparing for possible intubation. Monica watched in horror and relief as her son disappeared behind a wall of medical equipment and urgent voices. David stood frozen, realizing that the dismissive treatment they'd received for hours had nearly cost their son his life. Sterling found himself backed into a corner by the objective medical evidence. The code team's rapid assessment confirmed Park's diagnosis. Caleb was indeed in septic shock and needed immediate ICU care. But rather than acknowledge his dangerous misdiagnosis, Sterling chose to escalate the conflict. Even if this is sepsis, he said, his voice carrying cold calculation, intensive care requires significant resource allocation. ICU beds are limited, and we need to prioritize based on multiple factors, not just medical necessity, but realistic outcomes and resource utilization. The words were carefully chosen to sound medically reasonable while conveying their true meaning. This family doesn't deserve our best resources. Park stared at him in disbelief. Are you seriously suggesting we should let a 5-year-old die because you think his family can't pay? I'm suggesting, Sterling replied with professional detachment, that we have protocols for resource allocation that take multiple factors into account. This family will need to demonstrate their ability to cover intensive care costs before we can proceed with ICU admission. David felt something fundamental shift inside him. The careful humility he and Monica had cultivated for their son's education was dissolving in the face of a system that literally valued his child's life in dollars and cents. Monica spoke first, her voice shaking with fury and desperation. What do you need? What exactly do you need to save our son's life? Sterling's response was designed to end the conversation. ICU care for pediatric sepsis typically runs between $50,000 and $100,000. The hospital requires a significant deposit before admission, plus guarantees for ongoing costs. The number hung in the air like a weapon. To Sterling it represented an impossible barrier for the family he saw before him. To David Coleman, it was roughly what his company spent on a typical business lunch. David was already reaching for his phone, his hands steady despite the chaos around them. Jennifer, he said when his assistant answered immediately, recognizing the urgency in his voice even at this late hour, I need you to call Grace Memorial's CFO right now. Tell him David Coleman is in the emergency department with his son, and we need immediate ICU authorization. The change in the room was immediate and uncomfortable. Sterling's expression shifted from dismissive authority to confusion. Several staff members stopped what they were doing to process what they'd just heard. Also call Marcus, David continued, referring to his chief legal counsel, and get Richard Chen on the line. He's on Memorial's board. Tell them we have a situation that needs immediate attention. Monica watched her husband transform before her eyes. The modest facade they had maintained for Caleb's sake was falling away, replaced by the commanding presence that had built one of the Midwest's largest development companies. Sterling's world began to crumble as phone calls cascaded through Grace Memorial's administrative hierarchy. Within 20 minutes the emergency department's atmosphere shifted from routine medical care to crisis management mode. Dr. Elizabeth Hawkins, chief of staff, was the first administrator to arrive, having been roused from sleep by frantic calls from both the hospital's legal team and board members. She found Sterling in the hallway outside the ICU where Caleb had finally been transferred and was receiving the intensive care he should have gotten hours earlier. Howard, she said, her voice carrying the weight of institutional authority, I need you to explain to me how David Coleman's son spent 8 hours in our emergency department with septic shock. Sterling's face went pale. He knew the name. Every senior staff member at Grace Memorial knew David Coleman. The Angela Santos Coleman Pediatric Wing existed because of his family's generosity. The new cardiac catheterization lab bore his mother's name. His foundation's donations had funded equipment, research, and charity care throughout the hospital. But more than his donations, David Coleman represented power in the city's medical community. His companies employed thousands, his developments had revitalized neighborhoods, his influence extended throughout Chicago's business and political networks. The devastation on Sterling's face was complete. His hands shook as he tried to process the magnitude of his error, not just medical but moral and professional. The family he had dismissed with such casual cruelty had turned out to be among the most powerful and generous supporters of the institution where he had built his career. But worse than the professional implications was the undeniable truth of David's words. Stripped of medical jargon and institutional cover, Sterling's behavior was revealed for exactly what it was: racism dressed up as clinical judgment. "I didn't," Sterling began, but his voice died under the weight of indefensible choices. "You didn't what?" Monica asked, stepping forward. "You didn't mean to assume my professional training was worthless because I'm black. You didn't mean to dismiss my son's seizures as typical urban kid toughness. You didn't mean to suggest that families from our background overreact to medical emergencies." Dr. Hawkins watched the confrontation with grim satisfaction. In 15 years of hospital administration, she had seen the devastating effects of unconscious bias, but rarely had she witnessed such a clear-cut case of racism dressed as medical authority. "Dr. Sterling," she said, her voice cutting through the tension, "you have one chance to respond, and I suggest you choose your words very carefully, because they will determine whether you resign quietly or face a public investigation." Sterling looked around the hallway desperately. The nurses he had worked with for years avoided his gaze. The residents who had once respected his authority stared at him with new understanding. His kingdom of professional respect was crumbling in real time. "The patient," he started weakly, then stopped. There was no medical justification for what he had done. No protocol that explained why a businessman's anxiety had received immediate attention while a child's sepsis was dismissed. No professional standard that justified treating a registered nurse like an ignorant parent. David watched Sterling struggle with cold satisfaction. "You want to know what the most damaging part of this is, doctor? It's not just that you nearly killed my son. It's that you do this every day. How many other children have suffered because you decided their families didn't deserve your full attention? How many other black mothers have been dismissed as hysterical when they knew something was wrong?" The questions hung in the air like an indictment of Sterling's entire career. Around him, staff members were beginning to whisper, remembering other cases, other families who had complained about dismissive treatment, other times when Sterling's clinical judgment had seemed suspiciously aligned with his prejudices. Monica spoke again, her voice now carrying the authority of someone who had spent years fighting for respect in medical settings. 20 years of emergency medicine, you said. 20 years of deciding which lives matter most. 20 years of hiding racism behind medical degrees and institutional power. Sterling's career was over, and everyone in the hallway knew it. But more than his individual downfall, this moment represented something larger: the exposure of systematic biases that had operated in shadows for too long. "Security will escort you from the building," Dr. Hawkins announced. "Your access has been suspended pending investigation. Your patients will be transferred to other physicians immediately." As Sterling was led away, his steps uncertain and his face ashen, David called after him with one final observation: "Doctor, the next time you see a black family in your emergency room, if you ever work in one again, remember this moment. Remember what it cost you to assume that the color of someone's skin tells you everything you need to know about their worth." David sat with Monica in the waiting area, both of them exhausted but vigilant. They had removed their worn jackets, and David's expensive watch, usually hidden beneath his sleeve, was now visible. Monica's nursing credentials, which she carried in her purse, had been reviewed by the ICU staff, who were surprised to learn they were dealing with a medical professional whose concerns had been dismissed for hours. Dr. Park approached them, her expression grim but hopeful. "Caleb is responding well to treatment. We caught it in time," but she paused, choosing her words carefully. "If we had waited much longer, we would have been looking at potential organ failure." The implications hung heavy in the air. A child had nearly died, not because of medical complexity or resource limitations, but because of assumptions made by staff about his family's worth. Monica broke the silence. Dr. Park, how many other families go through this? How many children don't have the resources we have to fight back? It was the question that would drive everything that came next. Sterling's career at Grace Memorial effectively ended not with dramatic confrontation but with quiet, inexorable institutional pressure. The investigation that followed revealed a pattern of differential care that could no longer be ignored or explained away. Patient records showed longer wait times for certain demographics. Families with Medicaid received different levels of attention than those with private insurance. Hispanic and Black children were more likely to have their pain underestimated and their symptoms minimized. The patterns weren't dramatic enough to trigger automatic review, but they were consistent enough to reveal systematic bias. Dr. Hawkins presented Sterling with a choice: resign quietly with a neutral recommendation or face a formal peer review process that would likely result in professional discipline and public scrutiny. He chose resignation, leaving Grace Memorial 3 weeks after Caleb's crisis with a carefully worded statement about pursuing other opportunities. But individual accountability was only part of the response. David and Monica Coleman, drawing on both their personal experience and their resources, began pushing for systematic changes that would prevent other families from facing similar crises. The Coleman Foundation's Emergency Care Equity Initiative launched 6 months later with a clear mission: ensuring that every child received appropriate emergency care regardless of their family's apparent circumstances. Dr. Jennifer Park, whose courage in speaking up had likely saved Caleb's life, became the program's first medical director. What happened to Caleb wasn't unusual, Park explained to a room full of emergency medicine residents during one of her training sessions. Studies consistently show disparities in pediatric emergency care based on race, insurance status, and perceived socioeconomic level. These aren't usually deliberate acts of discrimination, they're unconscious biases that influence split-second decisions. But the impact on patients and families is the same. Sarah Martinez, the nurse who had struggled between conscience and fear during Caleb's crisis, found her voice through the Foundation's advocacy training. Her testimony about the pressures healthcare workers faced to maintain hierarchy rather than patient advocacy led to new protocols that protected staff who raised concerns about patient care. Amanda Brooks underwent a more complex transformation. The night of Caleb's crisis had shaken her understanding of her own role in healthcare delivery. Through mandatory bias training and peer support sessions, she began to recognize how her assumptions had influenced her patient interactions. "I thought I was being professional," she admitted during one of the Foundation's training sessions. "I thought I was following protocols, but I realized I had different protocols for different patients and I didn't even know I was doing it." Her journey from triage nurse to patient advocacy coordinator wasn't immediate or easy. It required months of additional training, peer mentoring, and honest self-examination. But her transformation became a model for how healthcare workers could recognize and address their own biases. David Coleman's response to his son's near-death experience extended far beyond Grace Memorial Hospital. Working with medical schools, hospital systems, and community organizations, the Coleman Foundation developed comprehensive programs to address healthcare disparities in emergency settings. The Foundation's work attracted attention from healthcare policy researchers who found that the Coleman family's experience reflected broader national patterns. Emergency departments across the country showed similar disparities in wait times, pain management, and treatment intensity based on patient demographics. Dr. Michael Roberts, a health policy researcher at Northwestern, partnered with the Foundation to study emergency care patterns across Chicago. The Coleman case was significant not because it was unusual but because it was typical, he explained to a congressional subcommittee studying healthcare disparities. Unconscious bias in healthcare settings isn't about individual prejudice, it's about systematic patterns that influence life and death decisions. Monica Coleman, who had taken leave from her nursing position to focus on advocacy work, brought a unique perspective to the Foundation's efforts. Her professional experience allowed her to speak credibly about the pressures healthcare workers faced, while her personal experience as a mother gave her advocacy moral authority. "I understood the system because I worked in it," she told a gathering of nurse administrators. "But that night I experienced it from the other side. I felt what families feel when their expertise is dismissed, when their concerns are minimized, when their children are seen as less deserving of attention." The Foundation's training programs began spreading to hospitals throughout the Midwest, then nationally. The protocols they developed for recognizing bias, advocating for patients, and ensuring equitable care became models for healthcare institutions seeking to address disparities in their own systems. Through all the policy changes, media attention, and systematic reforms, Caleb Coleman remained simply a little boy recovering from a serious illness. The sepsis had temporarily affected his kidney function, requiring weeks of careful monitoring and treatment. But children's resilience proved remarkable, and by spring he was running through their South Side apartment with renewed energy. The apartment remained their primary residence, a decision David and Monica reaffirmed after everything they had experienced. Their dual residence arrangement, the modest South Side apartment for daily life, the Lincoln Park house for business and formal entertaining, reflected their continued commitment to raising Caleb with awareness of different worlds he would need to navigate. "We didn't choose this life to punish him or us," Monica explained to Rosa Alvarez, the family's longtime housekeeper and confidant, one evening as they watched Caleb play. "We chose it because we want him to understand that respect has to be earned, that kindness matters more than money, and that his skin color will influence how people see him regardless of what car we drive." Rosa, who had raised concerns about their choice to live modestly, now understood its wisdom differently. "That night at the hospital," she said, "you learned something important. You learned that hiding your power can be as dangerous as flaunting it. But you also learned when it's time to use what you have." David looked up from reviewing foundation grant proposals. "The hardest part," he admitted, "is knowing that we almost lost him because of choices we made to teach him humility. If we had walked in there as the obviously wealthy Coleman family, he would have gotten immediate care," Monica finished. "But he also wouldn't understand why that's wrong. Their son would grow up knowing both privilege and responsibility, understanding that his opportunities weren't guaranteed and that power carried obligations to protect those without it." 3 years after that October night, the Coleman Foundation's impact was being felt throughout Chicago's healthcare system and beyond. Grace Memorial Hospital had become a model for equitable emergency care, with protocols that were being adopted by hospitals nationwide. Dr. Jennifer Park, now Chief of Pediatric Emergency Medicine at Grace Memorial, had transformed not just her own department but the broader approach to pediatric emergency care. The Sterling era's differential treatment patterns had been replaced by systematic protocols that ensured every child received appropriate care regardless of their family's apparent circumstances. Amanda Brooks, in her role as patient advocacy coordinator, had become a powerful voice for systematic change. Her transformation from someone who unconsciously perpetuated bias to someone who actively fought against it made her an effective trainer and mentor for other healthcare workers. "I tell people that I was part of the problem before I became part of the solution," she would say during training sessions. "But I also tell them that change is possible if we're willing to examine our own assumptions and commit to doing better." Sarah Martinez had been promoted to charge nurse in the emergency department, where she implemented protocols that empowered nursing staff to advocate for patients when they had concerns about care decisions. Her experience during Caleb's crisis had taught her that staying silent in the face of questionable medical decisions was itself a form of harm. The Foundation's research had documented significant improvements in emergency care disparities at hospitals that implemented their training programs. Wait times for pediatric patients became more equitable across demographic groups. Pain management protocols were applied more consistently. Family concerns were taken more seriously regardless of the family's apparent socio-economic status. On a warm morning in May, 4 years after that October night, 8-year-old Caleb Coleman walked into Grace Memorial Hospital holding his father's hand. They were there for the dedication of the Emergency Care Equity Center, a joint project of the Coleman Foundation and the hospital that would serve as a national training center for healthcare workers. Dr. Jennifer Park, now serving as the center's director alongside her clinical duties, knelt down to Caleb's eye level. "Do you remember being here before?" she asked gently. Caleb nodded seriously. "I was very sick. But you helped make me better, and now other children won't have to wait as long as I did." "That's right," Park replied. "Your mom and dad made sure of that." The dedication ceremony drew healthcare workers, policy researchers, and community advocates from across the country. The center represented more than just training programs. It embodied a commitment to seeing every patient as deserving of the best possible care. Amanda Brooks, now serving as the center's community outreach director, addressed the gathering. 4 years ago, I was part of a system that failed a 5-year-old boy and his family. Today I'm part of a system that's working to make sure no family faces what the Colemans faced. As the ceremony concluded, David and Monica Coleman stood together watching their son explore the center's interactive exhibits designed to teach empathy and cultural competence to healthcare workers. The past 4 years had been transformative not just for their family but for the way healthcare was delivered to vulnerable populations throughout the region. The silver angel pendant that had belonged to Monica's mother still hung around Caleb's neck, catching the afternoon light as he moved between exhibits. It remained a symbol of faith sustained through crisis, of love that transcended institutional barriers, and of the power of turning personal tragedy into systematic change. Dr. Sterling had moved to a small rural hospital in another state where his practice was closely supervised. His departure from Grace Memorial had been quiet, but his legacy, the patients who had received substandard care, the families who had been dismissed, continued to drive the Foundation's work. As they prepared to leave the hospital that day, Caleb ran back to his parents, his face bright with excitement about the children's area and the promise that sick kids would be helped faster now. "Can we see the wall with Grandma Angela's name?" he asked. They walked together to the pediatric wing where Angela Santos Coleman's name was inscribed on a marble memorial wall. Below it a smaller plaque had been added, "In memory of all who heal with compassion and in honor of those who fight to make that vision reality." Caleb traced his great-grandmother's name with his finger, understanding in his own 8-year-old way that families could be both humble and powerful, that kindness required strength, and that sometimes the most important battles were fought not for yourself but for people you might never meet. As they left Grace Memorial that day, David reflected on the journey that had brought them to this moment. The choice to live modestly had nearly cost them their son, but it had also given them the perspective to understand what needed to change. They had learned that privilege hidden was opportunity wasted, that true power came not from what you could buy but from what you chose to build. The silver angel pendant bounced gently against Caleb's chest as he walked between his parents, a child who would grow up understanding both the world's capacity for unfairness and its potential for transformation. Behind them, Grace Memorial Hospital continued its work of healing, forever changed by one October night when a family's determination had revealed the difference between providing medical care and truly caring for patients. The battle for equitable healthcare continued, but it was no longer fought alone in emergency room corridors. It had found voice, resources, and most importantly, the power of people who understood that justice delayed could literally be justice denied and were committed to ensuring it never happened again.